He's a distinguished researcher in the field of endodontics. He's internationally renowned expert in pulp biology and periapical pathology. He is a pioneer histological research advancing the understanding of root canal treatment and healing. Now, let's welcome Dr. Domenico Ricucci.
Thank you.
Thank you. Welcome, Professor. Welcome to be with us today here. So, for us, we have because we know you are very well known worldwide, and many of our customers, many doctors, they are a big fan of you. So, we collected some questions from our customers and our doctors. They want to ask you. So, let's start the interview today. So, first of all, it's well known that the endodontic community appreciates your extensive contributions to the field through your numerous published papers. So, which of your work do you think to be most relevant for the clinicians and likely to influence their treatment protocols?
Well, yes, I have published several papers, and some of them have a certain weight. Certainly, I would mention my study, which was published in Journal of Endodontics, about the correlation between clinical and histologic diagnosis. This is because the first papers discussing about a potential correlation date back to 1990, those years, and even before sometimes.
Yeah.
And you know, it was established at that time that there is not a correlation between the clinical diagnosis and the real histologic status of the pulp. So the clinician is often in doubt. Whenever the patient comes in with a very deep caries approximating to the pulp, the general dentist and even the endodontist are often in doubt. Should I treat the pulp conservatively? Should I try to maintain the pulp, or should I remove the pulp with a pulpectomy? This is a big problem in clinical dentistry. And with my research, with my co-workers, we were able to establish that if the clinician is taking care about collecting the history, symptoms, taking very good radiographs, and performing all the pulp testing, meaning cold, hot, electric test, then you have a good possibility to correctly diagnose also the macrobiologic status. So I will say something technical now, but when the clinical diagnosis is reversible pulpitis, the possible correlation with the macrobiology is almost 97%. So it means that it's a matter of time. You take time, you are meticulous in collecting the history, and you will know, you clinician will know whether bacteria have penetrated or not in the pulp. So this is one of the papers that I would like to mention. And then another one could be the one on the biofilms. You know that root canal infection between the era of the macrobiologists introducing the expression biofilm was confused. We were talking generically about root canal infection, about bacteria. We were talking about the possible several bacterial species present or not in the canals. But then the word biofilm was introduced by microbiologists, and biofilm is a complex community. Some bacterial species have the ability to form this complex community and live on the walls of the root canal system. So with my co-author José Siqueira, who is an excellent microbiologist, is from Brazil, in Rio de Janeiro, we were able to come to the conclusion that apical periodontitis lesion has to be included in the set of the biofilm-induced diseases. So the biofilm is our enemy. So in that paper we described extensively the characteristic, the morphologic characteristic of the biofilm in root canal infection, and we give a lot of percentages, association between small lesion and big lesion, cystic lesion, and the presence of biofilm.
Okay, thank you for your answer. I think you mentioned the paper you mentioned. They guide a lot for the doctors, and I can see that more and more doctors and researchers they're starting to study on the topics you mentioned just now. Okay, so the number 2 question is that endodontic is a dental specialty characterized by a variety of perspectives, primarily due to the complex biological factors involved in different treatment stages. So how do you navigate the controversies that arise regarding the biological and the technical aspects of endodontic science?
Yes. Your question is a very interesting one because you said, well, we have a lot of controversies in endodontics. Well, we have controversies in dentistry, but particularly in endodontics. And the most heated controversy in endodontics is certainly the apical limit of root canal instrumentation and obturation, and also the treatment of lateral canals. And I know, for example, that Dr. Castellucci was here before me a couple of months ago, and we belong to different schools. He belongs to the Schilder school. In the world, there are many followers of the Schilder school, starting from Buchanan, Ruddle in the US, Pierre Machtou in France. There are so many in the world, okay? But my side is the side of biology. And why this is a controversy? Because the other school in the past, now they have a little less success than in the past, they didn't have any consideration for the apical limit. They were instrumenting, according to Schilder, beyond the limit of the root canals, operating a little overextension of the instrumentation. Yeah, the biological school wants to try to stop the procedures, endodontic procedure, at the apical constriction, and during the course there will be way to describe this aspect extensively. So this is one of the controversies. Another one is related to the way of treating lateral canals, because it is regarded as a sign of clinical excellence when in the post-op radiograph you see some material filling. It is better to say injecting the lateral canals. So this is considered to be, a very good treatment, but this is irrelevant in fact, because from a biological point of view, unfortunately, and I have to stress the word unfortunately, we cannot clean lateral canals and apical ramification, and this is histology to demonstrate that. So at the same time, it is easy to push some obturation materials into them, but these materials actually are not filling the space because the space was not cleaned before. So once again, it is histologic investigation to demonstrate these scientific facts.
Okay, thank you for sharing. Because in recent years, more and more doctors, they are seeing the controversies, and they want to sometimes they are confused about how they should do. But we believe that there is no number one in the research of science. So everyone has the evidence, and we are willing to open to listen and learn the different experience,
Let me just mention another strong controversy, which is the way of treating canals in one visit or multiple visit. And for example, American endodontists prefer completing the endodontic treatment in one visit, and the reason is mainly one. It is an economical reason, because treating in one visit is profitable. Okay, if you treat in 2 or more visits, then you need more sittings and so on. It can be less profitable, but the problem once again is, if I fill the canals of a molar, of a tooth, in one visit, am I affecting the outcome? Am I reducing the prognosis? And for sure, when you treat a tooth in which the pulp is vital, that is without infection, it is recommended to fill in one visit, but whenever you start with conditions of an apical periodontitis lesion, a root canal infection, then if you fill in one visit, you have to know that you are reducing the prognosis for that patient. So from an ethical point of view, I would say that in cases with preoperative infection of the canals, treatment with intracanal medication is mandatory.
Okay, I see. Thank you for the sharing. So the third question is that, in your opinion, what are the key factors that contributes to the success of phytopulp therapy?
Yeah, this is another topic that is it's controversial in a way, because vital pulp therapy, as dentists know very well, includes direct pulp capping, partial pulpotomy, and pulpectomy. So the key factor, once again, is only one, and this is my point of view. The clinician should start to locate the front of infection. When I say front of infection, I mean the advancing front of infection, the deepest area of infection, which could be in the dentin, in the pulp tissue, in the pulp chamber. So the success, the clinical and histologic success, is obtained in the moment that all bacteria, infecting bacteria, are under control. And this is again related to another controversy, unfortunately, which is the depth of caries excavation. I have to tell you that at this moment in the world, there are groups who are pushing for something called selective caries excavation. Selective caries excavation means removing the caries lesion only partially, leaving a part of the softened dentin which is believed to be non-infected. Or their rationale is, even though you are leaving some remaining bacteria, these bacteria are going to die if the cavity is properly sealed. Well, I have to say that we have the evidence that this is not true. So what is called in the world as selective excavation, or also called like indirect pulp treatment, is something that is not substantiated by scientific fact. So I don't know the situation in China, but I really hope that dentists in China try to remove caries completely and try to control caries dentin completely.
Okay, thank you. Thank you for advice, and we are looking forward to your more sharing about this point in the lecture. Okay, so the next question is that looking toward the future, how do you perceive the trajectory of regenerative endodontics? Do you believe that endodontists and clinicians can rely on this treatment approach as a long-term solution?
So the story of regenerative endodontics, was very interesting since the beginning, which was about 25 years ago. And it was based mainly on radiographic appearance of immature teeth with pulp necrosis and periapical lesions, and controlling infection, and stimulating hemorrhage in the canal with the idea to attract mesenchymal stem cells, undifferentiated cells, and placing on top MTA. It was believed that this treatment would stimulate the differentiation of stem cells into new odontoblasts, which could produce new dentin. Well, radiographically, it was promising because you could see the thickening of the walls. So it was believed, well, maybe we are really regenerating the pulp dentin complex. But unfortunately, I was the one who processed for histology the first case in human in the world, because it was a case treated in Argentina, and endodontically the case was a success, but the tooth fractured, so they could extract the tooth, and they placed in formalin and they gave to me for histologic analysis, and we could demonstrate that unfortunately the newly formed mineralized tissue is not dentin. So the hard tissue which could be formed inside the root canal is never dentin, unfortunately. It could be a tissue resembling bone or cementum, sometimes periodontal ligament, which is something that clinically we do accept. But this has to be regarded as a form of repair rather than regeneration. So if we take it as a clinically advantageous treatment, it is true. It is better to do revascularization, regenerative procedure, rather than apexification. But however, this is going to be just a form of repair, and the long-term success depends exclusively on blocking the bacteria outside. I mean, you may have success in the first year, but then if the coronal restoration is not performed at the top level, and if it allows leakage of bacteria, you may have success at the beginning and then you have a failure in the long term because of the bacteria-tight restoration.
I see. Thank you. Thank you for the information.
You're welcome.
So the next question is that when selecting the most effective disinfection protocol for the intricate anatomy of root canal system, various propositions must be evaluated, including lasers, gentle wave technology, ultrasonics, and sonics. So which of these options would be considered the most advantageous or even practical for the clinician?
Well, you are talking about something that we clinicians desperately need today and in the future. So I have to say that the overall success rate in endodontics in the hand of a specialist, I'm not talking about general dentists, in the hand of a specialist today we can get a 90 to 95 success rate depending on the preoperative condition. So the remaining 10% failure that we do have are caused by the irregularities of the root canal system and are caused by our impossibility to control infection in irregular areas. So you mentioned sonic, ultrasonic agitation, laser agitation of the irrigant solution, and mostly there is the gentle wave, which is a multisonic new technique. But you know, the problem that we face today is the evaluation of these techniques. So the new techniques are welcome in the moment that there are relevant and serious investigations, mostly done in vivo. Today we have the problem that in the Western society, in the Western countries, in vivo experiments are not allowed to do, are not possible, not even in animal, because animal study would be something that may help, but this is not allowed to do. But however, as an alternative, you can use freshly extracted teeth where you perform the procedure, then the teeth could be fixed and processed for histopathology. That would be the final evidence, and we could understand if some procedure is worth of being acquired or not. So, but until now, I have to tell you that very little research is performed about this. So we continue to use sonic, ultrasonic agitation. We continue to use maybe laser agitation, but the final evidence is yet to come.
I see. So we need to still wait for some time to have some more research.
We rely on manufacturers. Manufacturers should try to invent new machines that will be able to clean irregularities of the root canal system.
I see.
Okay, and then this new machine should be validated with proper experiment.
Okay, thank you for your suggestion. So lastly, do you have any suggestions for dental manufacturers on how they can enhance their support for endodontic research and contribute to improved treatment outcomes?
Yeah, what I just said, this is my final recommendation, because I can see that you are here in this institution, you are investing a lot of money. I'm really impressed about what you do to improve the quality of the products and so on. I think that you could usefully cooperate with some research institution in order to find the way to completely clean the endodontic space. This is my dream as a researcher, and I always say that I would be very happy to cooperate in some of this research about the new technology if it is done on the biological aspect. Because, you know, I need to tell you that what is done routinely today is in vitro research. In vitro means in a laboratory, very far from the clinical reality. And this research cannot, the result of this research cannot be automatically translated to the clinic. So you need to pass in animal experiment, in human experiment, which I do repeat, unfortunately, is difficult today. But this is the only way. Let's imagine that if a seriously prepared protocol for an in vivo research should prove, should give the evidence that a new machine, a new device should be efficient 100% in cleaning lateral canals, apical ramification, isthmuses, I'm sure it would sell a lot in the world, because it will be the evidence that this is working, and it is helping us to go with our success rate from 90% to 100%. Which is our dream.
Yeah. It's also our dream. We always want to help our users to have better treatment, and also for the patient, for their health.
Yeah,
so
exactly.
Now we have the clear target. Thank you for your sincere advice. Okay, so thank you for your time to accepting our interview today.
Thank you for the invitation.
Looking forward to your lecture. Thank you.
Thank you. It's okay. Thank you.
Thank you, Professor.
Good.